For those of you who don't know me, I'm Glenn Dramani. I'm currently the co-director of workforce development for the TRI and working with Dr. James on developing this clinical trials course. Today, I have the pleasure of introducing Dr. Reed Landis, who I've also worked with over the past many years now. It's always great to learn from Reed. He has a way of making complex biostatistics very easy to understand. So Dr. Landis is a professor of biostatistics here. He's been helping with TRI initiatives also, such as the team science initiatives for many years. And I'm looking forward to learning from him more today. So I think you all will.
All right, good. So I got asked to do this talk, and I'm glad I got a chance to do this. They picked the title for me, and the title is Developing a Good Study Question. If they had asked me, what would you call this? I'd have said, that's a good question. So that's what we're going to be talking about. What makes a good question? Just some disclosures. I don't have any conflicts of interest, and I do receive funding from the TRI, also from collaborators that are funded by the NCI, the Veterans Administration, HSR&D, and the NIGMS. So that's where some of my funding comes from. And with that, I'll get into what we're talking about. We're interested in science. And before we start talking about what makes a good question, let's think about science and how it happens. Well, we see something interesting. And when we see something interesting, we wonder who or what experiences this interesting phenomenon. And then we look for things that might affect this phenomenon. Take, for example, Canis lupus. And 15 to 12,000 years ago, uh, dogs were becoming domesticated. They were becoming domesticated, and as this process was going on, there were attributes about some of those particular animals that were nice, especially as they became more friendly to the humans that they were around. We like this one. It alerts us to danger. I like that. I like that about this one, and so they take note of that. Ooh, I like this one right here. This uh, I'll say dog is smaller than the other. Doesn't take up so much room, but it's still ferocious to outsiders. And so we see these attributes, and we figure out how to hone in on those attributes. And here we are. So, that's where we're at science, kind of how part of it works. Another real example, I mean, this is a real example, but another example is the Flemings, they come home from holiday and Alex, he says, "Oh man, a bunch of mold got in my petri dish." And his wife Sarah says, "Ooh, it did. It killed all your little bacteria buggies too." And that's how we come up with penicillin. So we see something interesting. We wonder what is affected, what can we do to make that happen? So before I go any further, I will say that I am drawing a lot of this information. A lot of this information I've drawn from this article here. And yeah, so I'm just going to say this is a really nice article. It's short, and it covers a lot of ground really fast. So formulating research questions for evidence-based studies is a 2024 paper in the Journal of Medicine, Surgery, and Public Health. And I'll put that on the last slide. Okay, so talking about how science happens, there's some foundations that about conducting science and foundations. There's different sorts of studies, different sorts of things that we do, but those foundations all have some commonalities. Just like in a home foundations, there's different kinds of foundations or frameworks, but there's some commonalities. And those commonalities are we see something interesting. That's our outcome. And we wonder who or what experiences it. And so that's our population. And then we're looking for things that affect that outcome. And that's our factors. And those are the three foundational pilings of a good scientific question: your outcome, your population, and your factor under study. Now, I have put these in color, and hopefully the colors don't mess with your eyes too much. But the reason I put them in color is because on some of these pages, I have a bunch of text. And so these colors will hopefully make the text easier to understand. Okay, so that's why I've got the colors going on. So our three foundational pilings: outcome, population, and factors under study. On the factor, though, often it's the factor under study that best distinguishes what kind of study we're doing. Like home foundations, the framework for the study type varies, but it does have these three foundational pilings in them. Those frameworks are often can be defined by the factor under study. So a couple of study types that we'll talk about today is an intervention studies or intervention studies and diagnostic test accuracy studies. I picked these two because they seem like those are more along the lines of clinical trials that can happen. So those are two that we'll talk about today. Some other studies are prognostic studies to figure out what factors predict, give some insight into what will happen in the future or when it will happen in the future. Etiology and risk, what are the causes of something, and incidence and prevalence studies, which gives us how many people are affected by this particular condition. Economic and cost effectiveness studies, and then qualitative studies. And that paper that I talked about covers all of these studies. So if you're interested in these other study types, I'll refer you to that paper, and the references in that paper are also very useful. So again, we're dealing with intervention and diagnostic test accuracy studies. Let's talk about intervention studies for a moment. Intervention studies, they evaluate an intervention, most often compared to a control. Now that treatment intervention, it will tend to treat a disease or a condition. That intervention might be a preventative intervention, in that it prevents a disease or a condition, or maybe a supportive care intervention, which provides relief or comfort from a disease or a condition. Most clinical trials are intervention studies. And so it seems this is the big one that I'll talk about the most today. And the question framework for intervention study is the PICO framework. Sometimes you can put a T on the end of it, or an S, or a T and S on the end. And that PICO stands for population, some blue. Then intervention is the experimental treatment. C is for the control, is for the comparator, which is the control treatment or the condition. And these are yellow for the factor, for the type of factor. Then the O in PICO stands for the outcome, and that's the variable to be statistically analyzed, and it's in red. Then these optionals are time, the specified time frame, or maybe it's a longitudinal or repeated measures. The S can stand for study design, whether it's a parallel arms or crossover arms. So it's the PICO framework. What we want to do now is look at an example. This example is the aspirin study by Hoffman and Company, published in The Lancet in 2020. It's the low-dose aspirin for prevention of preterm delivery in nulliparous women with a singleton pregnancy. Or they figured that one out to come out to be aspirin, a randomized, double-blind, placebo-controlled trial. Yes, that's the title of the paper. Now, I pulled some text straight from the paper, and I'm going to show it to you now. It's a lot of, here we go. And the objective is to test the hypothesis that low-dose aspirin, that's our factor, at 81 milligrams, administered daily and initiated early in pregnancy, that's the time part of the PICO, between 6 weeks and 0 days of gestation and 13 weeks and 6 days of gestation, reduces the incidence of preterm delivery, that's our outcome, in nulliparous women with a singleton pregnancy, that's our population. Now, in this objective statement, their statement of their hypothesis, it doesn't clearly state the comparator. That's why I have the comparator in kind of a gray font right here. But from the title of the paper, we know that it's a placebo-controlled. So here is a way to frame that whole study into one question. What is the effectiveness of low-dose aspirin in preterm delivery prevention in nulliparous women compared with a placebo treatment? There. That covers the four things that the PICO of the question framework, framed into a concise study question. Another example. This is from Wong et al., also in The Lancet, and the title is Remdesivir in Adults with Severe COVID-19, a randomized, double-blind, placebo-controlled, multi-center trial. So from their objective statements and other portions close to it, it says, our study is a randomized, double-blind, placebo, in yellow because it's comparator, placebo-controlled clinical trial assessing the effect of intravenous remdesivir, that's our intervention, in adults, that's our population, admitted to hospital with severe COVID-19. So adults with severe COVID-19 is our population. A little bit later, they say the primary clinical endpoint was time to clinical improvement. I particularly appreciate this statement of the outcome because it gives me an idea of how that outcome is measured. So that objective, that hypothesis, that brief description can be put into a study question. And as per Hosseini et al., they said, what is the effectiveness of remdesivir for treating severe COVID-19 in adults compared with no or placebo treatment? There, a nice, concise study question. All right, so that is a couple of examples from an intervention study. Again, on an intervention study, the framework is PICO, population, intervention, comparator, and outcome. So next, we want to talk about a diagnostic test accuracy studies. And for these types of studies, a diagnostic test, or I'll simplify to DT, is if this kind of study compares a diagnostic test to a gold standard. Generally, diagnostic tests are easier than the gold standard. And when I say easier, I might mean it's less invasive, or it's faster, or it's cheaper, or some other nice combination of those. So diagnostic tests are generally easier than the gold standard. Diagnostic tests may identify the presence of a condition, or these diagnostic tests may rule out the presence of a condition. So those are what diagnostic test accuracies do, and a framework for asking questions. For setting up a good study question for a diagnostic test accuracy study is the PIRD framework. That stands for P for population, index test, that is the test that's under study, the diagnostic test under study. R for reference test, that's our gold standard. And diagnosis of interest is the outcome. So the yellow again are the factors that we're studying. Blue is the population, and the red diagnosis of interest is our outcome. All right, so the examples in the examples that I saw in the paper were dealing with meta-analyses. However, people do prospective diagnostic test accuracy studies. So here's one also from the Lancet. This is Johansson et al. In 2021. It's performance and operational feasibility of 2 diagnostic tests for cryptosporidiosis in children, CryptoPoc, a clinical prospective diagnostic accuracy study. So from their text, we have their objective statements and some things close to that objective statement. And so to evaluate the diagnostic accuracy of LEDAP and the lateral flow test strip, those are our index tests, for cryptosporidiosis, that's our diagnosis of interest, in children. So that's our population. Accuracy of each test was estimated by independent and blind comparison with a composite reference standard. And then they list several tests for their composite reference standard. And there's our reference part of the framework, the PIRD, the PIRD. The yellow again are the factors of interest. That's our one of the foundational pilings. The red are the outcomes, and the blue are the population. To frame this into a question, we could say, what is the diagnostic accuracy of LEDAP and lateral flow test strips for detecting cryptosporidiosis in young children? There. A tight study question. To come up with these tight study questions, it takes some iterations. It's with more practice, you can come to that the final version more quickly, but it still takes some iteration. So what I want to do is just do a hypothetical study. Several years ago, my dear brother pointed out to me, he says, "Woo, Reed, your hair's getting kind of thin up there." And I'm like, thanks, Dirk. Thanks for pointing that out. So this is the 2B and 2B study, standing for bettering baldness in big boys. And so the first study question that we came up with is, does treatment associate with baldness in men? So baldness is our outcome right here. And when you're thinking about your outcome, you want to think about how do I measure that? Is it a well-defined outcome? So this word baldness, that indicates my outcome. Is that binary? Oh, you are bald. Oh, you are not. Is it ordinal? Oh, you are completely bald. You are mostly bald. You're kind of bald. You're not bald at all. Or is it continuous? And I'm not sure how to do that right here, right now. But yeah, so to have a well-defined outcome. Also, can you give us some information about whether this outcome is measured only one time or is it repeatedly measured? So working with this first version, I'm thinking about the outcome of what I'm interested in, and we try to come up with a better phrasing for this outcome. How about this? Does treatment associate with hair regrowth over 6 months? So when I think about hair regrowth, there are ways to count the number of hair follicles in a particular spot on a person's head. So this would be a continuous outcome variable. And when I read that, I think, yeah, that's a pretty clear outcome. And it also gives me the idea that they will be measuring this outcome over time because it is regrowth and over 6 months. So great, that's our version 2. But next on this version 2, I've got this, does treatment associate with hair growth, regrowth over 6 months in men? Let's work on that one. That's the factor of interest. So is it a well-defined factor? Is it categorical? For example, treatment A, treatment B, treatment C, maybe placebo and active treatment. Is it ordinal? Is the treatment ordinal in that it's some people get one level of the treatment as none, or there might be a low setting for the treatment or a high setting for the treatment where it's very difficult to define what low and high are, except relative to each other. So is it an ordinal treatment? Is it a continuous treatment, kind of like a dose? If it's a dose, then that would be a continuous type treatment. Another question is it a one-time treatment? Do I just do it one time and I'm done? Or is it something that is done repeatedly? These are things to consider when you're thinking about defining your factor of interest. So, thought about that, and we've got, does weekly treatment associate with hair regrowth over 6 months in men compared to placebo salve? Okay, good. So now I've got this experimental treatment, and since the placebo is a salve, I'm assuming that the active treatment is also a salve of sorts. And I know that it's going to be done weekly and possibly over 6 months. But I also have the comparator as well, the comparator factor. And so now that has helped us better understand what this factor under study is. So there's our version 3 that we're now on, and now we're looking at men. Well, men are in different stages of life. So are we talking about, is it a well-defined population? Are we talking about men experiencing a midlife crisis? Maybe men with toddlers, because maybe that's kind of stressful. Or maybe men with teens, that can be kind of stressful. Or what if they've got teens and toddlers? Which at the time my brother pointed this out to me, this is where I was at. teens and toddlers. So there, we have updated our population to men with teens and toddlers, and is now well defined. So this does weekly treatment associate with hair regrowth over 6 months in men with teens and toddlers compared to a placebo salve. So we've defined all that, but then I have this word associate. That's kind of an ambiguous word. What do you mean by associate? So we think about that for a little bit. We're going to need some more clear language here. When I think about this treatment and how it associates, how it associates with our outcome, and then possibly compared to the placebo, a possible rewrite of this question is, by how much does weekly treatment differ in hair regrowth over 6 months in men with teens and toddlers compared to a placebo salve? So there, the rephrasing this way tells me that I'll be comparing the regrowth quantities between the active salve and the placebo salve. And this right here is our final question. You see that we have our factors of interest, weekly treatment, and placebo salve as our intervention and comparator. We have our population of interest, men with teens and toddlers. And then we have our outcome under study, which is hair regrowth over 6 months. And then this, how much does it differ, implies that it will be a parallel arm study. So just walked through an example of how you take an initial idea and work on it until you have a tight study question that takes care of your at least your 3 foundational pillars, your population, your factor of interest, and your outcome. And sometimes there's some other things in that framework. All right. So that is the bulk that I have on the foundations of building a good question. Now let's talk a little bit about towards clarity. Let's move towards clarity. One thing that I think a lot of investigators miss are the within versus among words. Within versus among words. So I'm fixing to run through a couple of examples, and hopefully you can remember these examples as you go about working on your study questions. The first one is this I put the photo credits down here. This is a fellow by the name of Andre. I don't know who that is, but this is Andre at one point in time, and this is Andre at another point in time. And here it is clear that Andre has changed. Andre has changed. This right here, Jimmy, has not changed because this is James. This is James and Jimmy. Jimmy has not necessarily changed into Jimmy. They are different. So the word change is talking about a within individual or within group word. Different is talking about among individuals or among groups. Okay. Similarly, we see that Andre has decreased in body fat over the time. And yeah, when you think about decrease, it's talking about an internal reference point. with an internal reference point to decrease. So Andre has decreased in body fat. However, James has not necessarily decreased in body fat, but he has less body fat than Jimmy. Okay, so less does not assume an internal reference point. Less does not assume an internal reference point. We see that Andre has increased in muscle mass over time, but has Jimmy increased in muscle mass? Has James increased in muscle mass? We don't know, but we do know that James has more muscle mass than Jimmy. More or greater than, greater, more, those two words, they do not assume an internal reference point. So therefore, among comparisons. So when you're thinking about using words like change, increase, decrease, difference, greater than, less than, maybe you can think about these two pictures and which one fits, which fits here. Anyway, okay, so those are two pictures to help hopefully drive home that point. Here is just an example is we might have a hypothesis that the experimental group will increase over time. The word increase is an internal, refers to an internal reference. So see, this is what we would picture, is that the experimental increases over time. Then we expect the increase in experimental to be greater than that in control. That word greater does not assume that internal reference point. That's an among group comparison. I'm comparing the experimental group to the control group. So this is often, this is an example that happens frequently. So that's one way to how these two different words are used, the within words and the among words. Now I just want to talk about the words among and between. So right here I say, somebody will tell me, hey, I want to compare among A, B, C, and D. I says, all right, you want to compare among A, B, C, and D. That is a general comparison. And when you say that, I'm thinking there's 6 different pairwise comparisons here. So which comparison are you interested in? Or which comparison are these, all of these comparisons of equal importance? So when you think about comparing among groups, just realize that's a general word and it doesn't bring much clarity. The word between, here we have compare between A and each of B, C, and D. Now, before I show you the next slide, I want you to just think about if you were to place arrows, where would you place arrows? Compare between A and each of B, C, and D. Hopefully, you came up with something like this. And this is a more clear phrasing of the comparisons that we are interested in. Okay, so those are just a couple of things to consider, a couple of ways to clarify your language in your questions as you write your study questions. So to wrap up, there are 3 foundational pilings for a good question. You've got your outcomes, your populations, and your factors. The outcomes are the things that you measure, that you're interested in, that you want to, yeah, the things that you measure and that you will likely statistically analyze. The population are the groups of things or the groups of people that you want to have these outcomes or that do have these outcomes. And the factors are those things that affect the outcome. Among different study types, there are different question frameworks. However, among those different question frameworks, they all have these three foundational pylons. And finally, when you're writing your study question, you want to strive for clear and concise language. So that is my wrap up of how you can come up with a question where people will say, that's a good question. That's a good question. And there's a nice, concise reference for you.
So I have a question.
Sure.
So how do you think about including when you're thinking about using data sources that include things like wearables or social determinants of health, EHR data? What would be your thoughts around building a question when you have this type of data as your source?
First is to think about those three foundational elements of a good question. The outcomes that are in that EHR that you're interested in. If you have an example that you want to know, maybe we can come up with something. But yeah, the outcomes. The EHR has all kinds of populations in it. To focus in on the population of interest, and then what factors, what's something that varies within that population, a factor that might be related to that outcome. Whether I clearly answered your question, I'm not sure. I will say that maybe the type of study you're talking about is not like a clinical trial where it's a prospective experiment, if you will. And to that, I'll refer you to that reference article, that article I put up there, and the references therein. But again, to always think about what are those three pillars in your study.
Okay, thanks.
I have a question for Dr. Landis. So when it comes to outcomes, Dr. Landis, from a statistical point of view, is it better to use continuous variables or categorical variables? For example, lipids. I mean, you can look at them as a continuous variable, but you can also classify based on what clinicians use as reference, right, to diagnose patients.
My professional opinion on that is I would start with continuous, and then if it makes good sense to dichotomize or to cut it up into groups. If you start with already dichotomized data, it's very difficult or impossible to go from aggregate pieces to fine pieces, to go from gross to fine. However, you can go from fine to gross very easily. But generally speaking, I would say continuous would be the way to go. For example, this morning I got up, I weighed myself, and I was I was my BMI was 24.9. But then I ate lunch and now my BMI is 25.1. But does it really make a difference? So I would say continuous is generally the first thing to go for. And then if it makes sense, go to some categorized grouping. Ooh, you know what? I'm going to talk a smidge more on that, Eva. Um, the other day, I was working with somebody and it was an ordinal scale. It was quality of life measures. It was my quality of life is, I'm not using the exact wording. My quality of life is awful. My quality of life is fair. My quality of life is good and excellent. And we when you choose to dichotomize on something, if you get to choose where you dichotomize, that can be useful. If, for example, I've got four choices. It's awful, it's fair, it's good, it's excellent. If, for example, I was interested in only the awful people, but there were only like 10% of the awful people, then that would not be a great dichotomization because I'd have 10% right here and 90% over here. If I had, let's say, 45% of my people said fair, so now I've got 55% in fair and awful, and 45% in good and excellent. That's a better dichotomization because the percentages between the dichotomies are closer to 0.5. If your dichotomization is half and half, like literally half and half, that is that's optimal. It's optimal because the variability between half and half is more. You've got more variability that you can explain if it's half and half than if you have 10% and 90%. There's not as much variability there. Okay. Yeah, I do hope y'all remember the two before and after shots. I hope you can use that to remember the difference between changes and differences. Okay, I'm done.
I just said, thank you, Reed. You do a great job of explaining complex concepts in a way that are very understandable and that we can remember. I'm just going to draw everybody's attention to the REDCap link. We appreciate your evaluation. As you know, this is the first year that we've done this. We've had a great response, I think, from the audience, and we are gearing up to plan year 2, which will not start until December. But if you have burning topics, questions, anything relating to clinical trials, we would love to feature that in this clinical trials learning collaborative. So thanks everybody. And thanks again, Reed. See everybody in September. Take care. Have a good day.